Hello, my name is Dr. Grace Wanjiku. I am an emergency physician at the Division of Global Emergency Medicine at Brown University. Thank you so much for attending my talk today. And the topic is utility of handheld ultrasound for image acquisition and interpretation by trained Kenyan providers. I have no conflicts of interest to declare. So the topic that I'm going to be talking about is based on the work that I have done in the past with Emergency Medicine Kenya Foundation. I started working with them back when I was a resident doing my training in emergency medicine. And at the time, they had a pretty large nationwide training program. As you can see, these are the facilities where the trainees were drawn from. So it's a pretty large national program. And the way the training program worked was that there was a phase one where the trainees received pre-training materials. It was text, was videos that they would watch, and they were required to take a test and pass it before presenting for phase two, which was held at the capital city. So they traveled to Nairobi, where upon arrival, they did a pre-training observed standardized clinical exam. So this was basically them scanning healthy volunteers who are already pre-scanned, and they would be observed and scored on their image acquisition and image interpretation. And the topics were EFAST and focused obstetrics. So after that would be followed by a pretty intensive 2 to 3 days hands-on training and scanning. After that, they would do a post-training OSCE and a post-training multiple choice test. After the training, they would receive a donated ultrasound to take back with them to their facilities to use clinically. And then 4 months after that was phase three. And actually, when I started working with Emergency Medicine Kenya Foundation, I started with phase three, where my job was to visit the facilities where the trainees were located across the country, which was a fun experience. And we would do in-training, in-facility OSCEs and multiple choice tests. At the time, this was the only way we really could do any QA in terms of how the trainees were doing, because the machines that were donated to them did not have any way for them to export the images or transmit the images for remote review. And so we had to do on-site testing to evaluate, see how they're doing. After that, 4 months later, the people who did not pass the in-facility testing, and a lot of people did not pass it the first go around, they would have to come back into the city again for refresher, retraining, and group OSCE and multiple choice tests. And so the process would repeat itself until the trainee was deemed to be competent. So, sorry, I'm gonna just move the recording screen. It's probably better to be here. As we all know, as point of care ultrasound practitioners in low and middle income countries or in areas of low resources, there are several challenges that are chronic that we deal with on a regular basis. First of all, POCUS trainers are always in short supply. So this is an issue that we deal with all the time. And the availability of ultrasound machines is the second issue. And for this one, we really need ultrasound machines that are reasonably priced. We need ultrasound machines that are durable. We need ultrasound machines that have good image quality. We need some sort of image storage and image interpretation for remote review. And this one really feeds back into the fact that we don't have enough POCUS trainers to be in the facilities, to be at the bedside teaching and supporting. And so the next best thing we can do is having these trainees who are located in far off areas send us their images. We can review them and give them feedback. So going back to our training program in rural Kenya, when I started in 2015, there was very few trainers. There were really only 3 of us, and we would be joined by a rotating group of invited trainers, but it was a really small group of trainers at the time. That has changed now in that we have a larger group of people who are certified to be POCUS trainers. But definitely when we started, the number was very limited. In terms of ultrasound machines, this is the machine that was being used in rural Kenya. As you can see, it's a notebook type ultrasound. It was donated to us by a charitable foundation, but they obtained it at about 3,000 US dollars. And so it was pretty reasonably priced, pretty durable. I mean, these ultrasound machines are still out there in rural Kenya. They're still functional. And so, durability is key when you're working in low resource and geographically isolated areas. Image quality, I kind of put a question mark on it because I would say it was adequate for the very basic functions of 2D ultrasound, of M mode. We did not have any spectral Doppler, no color Doppler, but I would say that just for basic applications, which is, finding fluid, doing an EFAST, doing basic focused obstetrics, it was adequate. The machines are adequate, I would say. In terms of image storage, these machines could allow you to store images, a limited number of images and clips on the machine itself, but we had no way of getting those images out of the machine, either through a USB or CD or any other kind of storage where they could then be uploaded for image review. So this was a huge challenge for us as trainers. And it meant that really the only way we could do image review was by visiting the facility while doing the OSCEs, while doing the multiple choice, test questions. We would review the images that they have been obtaining. Sometimes the trainees would use their photos, would use their phones to record the images and send to us via WhatsApp. So really, I think we just did not have a robust process for image storage. We did not have a robust process for image transmission. So then come 2018, we got the opportunity to trial a handheld ultrasound. This was right before the Butterfly IQ went into market. We got the chance to trial it within our rural ultrasound cohort. And basically what we were excited about, or what the prospects for us was that these were reasonably priced. The price point was attractive to us. We did not know about durability at the time. We were going to test that. We did not know about image quality because this is the first time we had used the handheld. We were very attracted by the fact that there was image storage, which is cloud storage, and that it was possible to transmit images from this machine by connecting it to a phone, which was connected to local cell phone networks. So these two were very attractive to us as well, in addition to the price point. So then we designed a study, and the reason we did this is that we wanted to compare the handheld with the notebook ultrasound that was out there in rural Kenya that our trainees were using. And we wanted to see how they compared in terms of image quality, image interpretation, and image transmission. So this study was a while ago in April 2018, and it was a small pilot study that was designed as a non-inferiority trial of the handheld compared to the notebook ultrasound. The participants were prior point-of-care ultrasound trainees who were coming in for a refresher. So these are people who had received initial training. They had received in-facility training 4 months after that, and they were deemed to require a refresher 4 months later. So then they came into the city, and the way the refresher happens is that we kind of do retraining with them. We go over the issues that they are having difficulty with. And after that, they do post-training OSCE and post-training multiple choice questions. So during this trial, this cohort that had come into the city was introduced to Butterfly IQ, the handheld. We did a 2-hour introduction where we taught them how it works, how it connects, and how they can use it for image acquisition and interpretation. We also showed them how to store the images and to transmit them. So we did our usual retraining, our usual OSCE, only that this time the trainees did the OSCE twice. So they did it with the notebook ultrasound that they were used to, the ones that they use in their facilities, and they also did the OSCE with the handheld ultrasound. So the OSCE, in terms of how it is graded, this is the form that we use here. As you can see on this picture, these forms are very ubiquitous in our training program because we use them a lot to grade and score the trainees and see how they're doing. So this is one of our trainer here is observing a trainee scan and scoring them on this sheet. So as you can see here, we do EFAST and focused obstetrics topics. PO is position, orientation of the probe, anatomy. So they are required to call out the anatomy that they can see. They are required to interpret what is going on, and also asking them questions like, if the patient had free fluid, where would you expect it to be? And they are also scored on image quality. So our study focused on image quality and image interpretation. So the scoring for image quality is on a scale of 0 to 4, where 0 would be no meaningful images generated. 1 is poor images. We can see some anatomy, but it's not sufficient for interpretation. 2 means that they obtain good images, which are acceptable for interpretation. 3 means that they obtained excellent images with minor suggestions for improvement, whereas 4 is outstanding images with no suggestion for improvement. For interpretation, the scale is 0 to 3, where 0 is that they did not acquire images sufficient for interpretation to answer point of care questions. 1 is that they correctly acquired images, but incorrectly interpreted some of them. 2 means that they correctly acquired images. They were able to interpret some of them, but not all relevant point of care questions. For 3, they correctly acquired and interpreted all images to answer all relevant point of care questions. So image quality 0 to 4, image interpretation 0 to 3. So in terms of our results, for EFAST, we had a total of 5 trainees who came for retraining on that day, and they obtained a total of 60 images which were available for evaluation. So for EFAST image quality, the median score, so we reported the median scores here of the notebook ultrasound compared to the handheld, we did see that the notebook ultrasound was significantly better. So it was superior to the handheld for EFAST image quality. But when it came to image interpretation, there were no significant differences between the notebook and the handheld. For focused obstetrics, once again, with our 5 trainees, there were 60 images and 60 clips available for evaluation. For image quality, looking at the median scores, there was no difference. There was no statistically significant difference between the notebook and the handheld. And for image interpretation, we did not find any significant differences either. So we went ahead and looked at, I'm going to just move this a little bit. We broke down the views. So for example, EFAST, we broke it down to the different components of the EFAST, and we looked at image quality between the handheld and the notebook ultrasound. And what we saw was that there were no statistically significant differences when we broke down into each component. So subxiphoid, we saw that there was no difference. In terms of obstetrics, the same thing too. We just did not, all the way down, we did not see any statistically significant differences in image quality between the handheld and the notebook ultrasound. The same case was found for image interpretation. So looking at the handheld and notebook, going down the table, we did not find any statistically significant differences in image interpretation between the 2 ultrasound systems. So in terms of image transmission, images that were obtained with the notebook, like I talked about, there was no way for transmitting them for remote review. And so we had to take the machine itself to give it to a remote reviewer, as opposed to the handheld, as you can see here, was connected to an iPhone. And this iPhone had a SIM card from a local phone network. At the time, we only had 3G available. So the images were saved here and they were transmitted into the cloud, and they were available within 2 to 3 minutes. So that means that anyone in the world who had access to the cloud account could look at those images and could give feedback. So in summary, what we found was the handheld ultrasound was non-inferior to the notebook in measures of EFAST image interpretation, focused obstetric image quality, and focused obstetric image interpretation. The handheld ultrasound was found to be inferior on measures of EFAST image quality. When comparing separate imaging views, the handheld was found to be non-inferior on all measures. So there were some key limitations in our study. First of all, this was a small pilot study. So we had 5 trainees and they obtained a total of 120 images that were available for evaluation. We had, I would say our study has limited external validity because we looked at the handheld, comparing it to a very specific notebook. You know, it can be argued that if you're comparing the handheld with other conventional ultrasounds or cart-based ultrasounds, that they might perform differently. So we are aware that these findings that we have are applicable to our cohort in our training program in the particular ultrasound system that we have. So it's important, I would say, to look at our results and compare with other people who have tested handhelds and compared it with other models of conventional ultrasound. The other thing was that our study was in a controlled environment. So these were trainees, healthcare providers who were scanning pretty healthy volunteers, healthy pre-scanned volunteers. Other studies that have looked at handhelds and compared with other ultrasounds have done it in a clinical environment. So in a way, you can design this differently to take the handheld into a clinical environment where you're scanning and you're making clinical decisions based on your findings and compare how they perform in that environment. The other issue for us was that all the images that we looked at and scored were also scored by an external rater. And the agreement between the internal and external raters for obstetric image quality was pretty good. So we obtained 80% agreement for the notebook and 83% for handheld. However, the agreement for EFAS image quality was pretty low. So what this means is that it makes it difficult for us to really interpret the image, the EFAS data, right? I would say that in this study, obstetrics data is more robust in compared to the EFAS data, looking at the agreement. And I would say that what we could have done is that we probably could have gotten a third rater just to kind of adjudicate any differences between the internal and external rater. But just as a limitation, this was pretty low, I would say. Our obstetrics results, as I was saying, they compare pretty well with a study that was done in 2019. So the year after, this study that was titled Reliability of Ultrasound Findings Acquired with Handheld Apparatus to Inform Urgent Obstetric Diagnosis in a High Volume Resource Limited Setting. So this was done in Sierra Leone. It was done in a clinical setting. It was a single center prospective observational study. They had 5 operators, similar to ours. And these handheld operators scanned a total of 307 pregnant patients. These patients were rescanned again by an experienced OBGYN provider using a conventional ultrasound. The results they found was that the handheld was found to be as reliable as a traditional ultrasound in structured obstetric ultrasound exams. And the agreement also between the external and internal raters was pretty good. So I would say that it compares fairly well with the results from our pilot study. So in conclusion, comparing the handheld with the conventional ultrasound, one of our collaborators was pretty excited about this study. I would say that overall, our findings were that the handheld is reasonably priced. We still have questions about durability, just because we know that, you know, our notebook ultrasounds have been out there since 2015. They're still kicking, still strong. We still need to collect more data or to have more long-term follow-up to see how durable and how well the handhelds are gonna perform out there in small clinics in isolated areas. The image quality was found to be good, or at least comparable to what we already had. Image storage and image transmission is a great plus. I would say that a lot of Kenyan providers and a lot of Kenyans in general access the internet through their phones. And so the ability to connect the handheld to a phone that has a SIM card from a local cell phone network, or even a tablet that has a SIM card from a local cell phone network, really helps in the process of image transmission. And it really helps us as trainers or people who are starting programs, especially if you have a large program or a program that has trainees that are very kind of geographically spread out. The ability to have this, the ability to be able to design a platform for remote review has been a welcome plus for us. In addition, we have received, from some of these up and coming companies that are making handhelds, they also come with an educational platform, which is an additional boost for our trainees when they want to access learning materials separate from their scheduled training program. So that is all I have for today. And thank you so much once again for listening. And I will welcome any questions.